which are treated, which is the light blue, is always higher than the bars which are in dark blue, those which have been tested. And on a median value, is only around 10% of the children which goes to the private sector, which get a testing for malaria. When we look at other type of surveys, ACT Watch surveys, many of the tests used in the private sector are malaria RDTs. While if we look into the medical private sector, formal private sector is more microscopy. And this difference between testing and treated shows that there is a lot of anti-malaria in the private sector which are still done on a presumptive basis without any confirmation. Now, this is the background of the consultation. If you go to the next, is actually we try to identify some objectives from the meeting. On the next slide, first we wanted to review the evidence in which actually supports more efforts in engaging the private sector, because WHO in influence on member states, we paid good attention on the policies, the regulations, which affect both the use of malaria medicines, antibiotics, and in vitro diagnostics. We also looked at what are the evidence gaps, which were clearly we need more also research. And we paid attention to those large-scale initiatives involving multiple countries where the experience was brought up scales, including, for instance, the AMFM, or more recently the co-payment funding mechanism of the Global Fund, the UNITAID projects of creating a private sector market for quality assured RDTs, the large-scale use of accredited drug dispensing outlets projects in Tanzania, and the experience of the Global Fund in creating a framework for engaging the private sector in malaria case management. We also looked through multiple types of surveys to the major determinants of the supply chain and distribution mechanisms which affect access. And we had also some lessons learned from the TB program, from family planning, and other public health programs which have done good engagement with the private sector. So go to the next slide. We can see the process that we had for the consultation. We had a very good and engaged group of, I would say, like a steering committee, which has followed all preparations of the meeting. And you will recognize here many of the names of which are really key in the RBM Case Management Working Group. We had very good advice on the key resources, including surveys to be done before the meeting, the analytic work, and the sort of resources to be used during the meeting itself. The meeting was from 1st to 3rd of May this year, involved over 70 participants, and we had from each of these 7 countries selected as case studies, around 2-3 staff members from the Ministry of Health, from the national regulatory authorities who attended for each of the countries. We also had several experts involved in the regulatory reviews, outlet surveys, and research, and also private sector representative. We had over 10 manufacturers of pre-qualified ACTs and pre-qualified RDTs. And also we collected information from first-line buyers in key countries with a survey. So all this was actually resources made available at the meeting. We had the CHAI, Malaria Consortium, and PSI involved in doing some case studies in countries, preparing some country policy profiles, which were looking in detail on the regulations, the policies, the alignment with national strategic plans for malaria medicines, antibiotics, and in vitro diagnostics. And we also had a comparative analysis made by Taruni Kurana, a PhD student, who actually compared the results across the 7 countries. And as I said, also the results of a survey of first-line buyers involved on ACT co-payment scheme with the Global Fund, which were from Ghana, Kenya, Nigeria, Tanzania, and Uganda. Then during the meeting, in addition to the classic presentation discussion, we also had working groups where we used a special planning tool and analytic tool by PSI, adapted from the Keystone Design Framework, where we looked into the market constraints along the supply chain, how to reduce the barriers, and how to promote best practice to improve access to quality of care, both in the short term, 1-2 years, as well as to the 3-5 time period. So if you go to the next slide, we had out of the meeting a very strong consensus that the private sector is central to universal health coverage. And as there is a great proportion of patients which access quality care through the private sector, this sector needs to be able to deliver quality malaria case management. And the obvious is it is part of the national health system. It is certainly part of the national strategic plans. But when it comes to implementation of case management activities, there is often, this is not prioritized or gets as a secondary attention compared to other areas of intervention for malaria case management. So the next slide reviews some of the findings for the stated objectives. First, there is, in general, quite limited evidence on different ways to improve malaria case management in the private medicine retail sector. This is where you have the pharmacies, the accredited and informal drug shops, and all the informal private sector. And there's been a major obstacle, even in the research settings, and Unitaid project was really a good learning on this, that there are regulatory restrictions on who can test, who can actually sell the test or perform them, and the other the possibility to prescribe or sell medicines. And a difference also between medicines for malaria and antibiotics. And this needs to be harmonized even during the research phases of the different projects. And when these are obtained as waivers for a project phase, for a research, and they are basically things go back to normal, then there are serious obstacles to implement good case management in the private sector. Also, in terms of availability, affordability, there has been a lot of evidence on the impact of subsidies or co-payment schemes, which could crowd out, which could actually allow wider availability of malaria medicines, and especially when they are strongly supported by behavior change and communication programs. However, when these programs don't have also a good emphasis and penetration and promotion of diagnostic testings, then the increased availability and affordability of ACTs leads to a lot of inappropriate use of these medicines for non-malaria fevers. In terms of the next slide, if you move to quality of care aspects, there is also, if we compare the research, the knowledge basis, there is limited evidence on the best way on how to introduce malaria RDTs in the private medicine retail sector. There is a lot of evidence that the staff from the private sector can perform very well the test and also adhere to the test results, even better sometimes than the formal healthcare workers. However, this requires appropriate training and regular follow-up, like it needs in the public sector. And also in terms of quality of care, there is a need for appropriate protocols for management of non-malaria fevers, which should be adapted to the specific settings of private sector delivery in resource-limited settings. In terms of knowledge for the consumer providers, there is evidence that behavior change communication activities are effective, but generally with sustained implementation, 6 months and beyond. And generally, in terms of demand for services, there is still limited demand for testing in some settings, and the RDTs are often seen as a commodity, not as a service. And a big, I would say, black spot in terms of surveillance, there is little experience on how to have appropriate system for surveillance involving the private sector. So a lot of the data on treatment is actually not captured and doesn't really integrate with the malaria surveillance system. So if you move to the second objectives, we had some review of around regulations and enforcement. There is clearly heterogeneity in terms of implementation. All countries have certainly regulations and registration requirements for both ACTs and RDTs, but for the RDTs, a lot of the policy and regulations are still evolving. There is generally, in terms especially of diagnostic testing and use of antibiotics, limited capacity to enforce regulation by the regulatory authorities. So there are rules and regulations, but then practice is often very different. And in the table, you see in this slide, a very big difference between the way antibiotics are considered in most countries as prescription-only medicines, while for ACTs, in most countries, they are over-the-counter, except for Kenya. And most countries, especially the first-line treatment, like in Tanzania, Uganda, is also considered over-the-counter. So this makes a big difference in terms of using the appropriate case management protocol when you have no malaria fever and somebody is RDT negative and fits, for instance, classification, diagnosis, symptomatic of pneumonia. If you go to the next slides, we also have a difference in how the RDTs are considered by these countries. If we look at these 7 countries, some countries like Kenya, Tanzania, were considering the RDTs in a higher level of risk in terms of in vitro diagnostics, while for Ghana and Nigeria, these were considered as lower risk diagnostics. And this affects actually where the test can be done, so in which premises, by which levels of professionals, and whether they are able to, allowed, I would say, to perform or to sell. So just to give you some example in this table, if you look at DRC, in DRC, the policy actually restricts limits the use of the RDTs, their performance and sale only by some pharmacies where there are licensed pharmacists. And on the contrary, the policy allows to be used by community health workers, which is again probably a contradiction in terms of capacity and skills of health workers in properly doing the test and using the results. Also for Tanzania and Uganda, there is still those which are allowed involve lab technicians, the drug shops with accredited, and also community workers. But in some of these countries, the pharmacies, again, are not allowed to perform, but they can sell the RDTs. So if we go to the next slide, in terms of in learning from other experience, we had the presentations from the Shop Plus projects showing very interesting work in Ghana, where they were allowed to introduce ORS and zinc by chemical sellers and reduce overconsumption of antibiotics for diarrhea. This was a very good example of engaging private sector. And for us also very good lessons learned from the TB programs, which have a roadmap which involves very systematic set of activities which are important to guide the Ministry of Health to properly engage the private sector, from situation analysis to setting then some appropriate objectives, and then a strong advocacy, allocation of resources, involving multiple partners inside the countries, then to have a fully aligned and supportive policy environment to then move into flexible models, and having in use of a new technology like this different type of mobile technology for data transmission, to then deliver on a different set of financial and non-financial incentives, and then to have a monitoring framework. So a very comprehensive approach to what they call public-private mix for prevention and care of TB in the private sector. So if you go to the next slide, I'm going to present what has been emerging from the consultation. And even if we don't have yet the final report, is now just been circulated since few days to all the participants, I think it was good that we present and share here what are the common themes which are emerging. And clearly, as I say, the big point is that there should be more promotion from all governments, from the malaria programs and the key stakeholders in the countries, to have the better quality of care in the private sector, and this should be promoted in the general population. So this should be really through stronger promotion of also approaches that promote again the test, treat, and track, the T3 approach that was introduced a few years ago, but is still not fully taking up in the private sector. In terms of quality, there should be increased demand and mechanisms to basically promote trust in the population, and one of the systems is the accreditation of drug shops, as well as having investment in training program for the private sector providers on the management of non-malaria fevers. And having also worked with the professional association and development schemes for increasing knowledge and capacity of private sector providers. Also, this activity of increasing availability and affordability of both diagnostics and medicines should be continuing on and building on the good results that the AMFM co-payment scheme has done, but adding also the diagnostics component. The next slides will give us what is emerging on policy and regulations. The country policies should be really reviewed, and there is a lot, as I showed, with some inconsistency between medicines for malaria and antibacterial, antibiotics. The problems with, again, regulating testing versus giving the medicines are all areas which really require the harmonization. And it's important that especially the policies allow testing where prescription and selling of medicines is being done to promote rational drug use. Also, there is generally, if we look at national strategic plans, a very positive environment and support of engaging the private sector, but this is not aligned with what is still in the regulatory frameworks of the countries and in the restrictions that are sometimes put on different commodities. For instance, price is often different in terms of taxation on imports for medicines, which get exemptions, while testing in many countries they are still charged on importation. Also, there should be generally, again, more guidance that on the management of negative test results. As I said, the guidance to be developed and adapted to private sector settings and in areas where there are limited resources, and also to have a system to promote some form of OTSS, outreach, training and supervision support, also involving the private sector. On the next slide, some on the market information. This is also what the TV roadmap was putting as step one. Also for malaria, we need more information on the market dynamics in the private sector, especially outside of the large urban areas. And important to note that we have up to 40% of the population with the lowest income which uses the private sector. So it's not only for the people which have higher education, higher income to use the private sector. On the surveillance, as I said, we have a major need to develop systems which can be then integrated in the National Malaria Information System. We have on pricing and incentives, the system which should improve affordability, availability of quality medicines are important. And what was the feedback coming from the first-line buyers is that with the suspension of the co-payment mechanism in countries like Nigeria, there is moving back to other types of ICTs which do not meet international quality standards because they are clearly cheaper. So the loss of co-payment, the loss of subsidies brings the situation back to, let's say, before pre-project, pre-initiatives, which again, availability of lower price medicines, often of heterogeneous quality. Then there should be again some more work on looking at affordability of testing and treatment as a whole, as a package of intervention, and not just the medicine. And alignment on taxation systems between the diagnostics and medicines. At the moment, there are clearly more taxation on diagnostics than medicines. Also, the last point, which was strongly emerging, the need for better coordination among different stakeholders on the way of delivering case management. There is still different agencies which have promotions which are sometimes dogmatically going on only community health workers, others going only on the private sector. And there is clearly a role in most countries to have extension beyond the coverage of the health facilities, involving both community system as well as private sector intervention. But this is an area where we need, again, RBM case management working group and harmonization of stakeholders at country level. So in the last two slides, let me move quickly. There were also some key requests to WHO at this meeting. Not always this is the case, but clearly to have a strong voice on advocating for more activities to ensure quality case management in the private sector, and seeing the private sector as an essential delivery platform for achieving universal health coverage. As I mentioned already, many need for support and guidance to governments to how to facilitate coordination across multiple stakeholders involved in not only the malaria programs, but the regulatory authorities, the professional association, the industry association, and when it comes to taxation, other sectors like the Ministry of Finance. And very important, the capacity to give some guidance to malaria programs, how to make some, let's say, decision-making tools when it's appropriate to allocate part of the grants, could be international grants like from Global Fund, for private sector strengthening or improving quality of care in the private sector, while this may be competing with other priorities which are also very important and needs support. In terms of quality case management, there is a need to how to better assess quality of care in the private sector. We don't have specific tools for this. Promotion of malaria diagnostics in the, again, private sector, and this we clearly see there is a major lagging behind the private sector compared to public sector. And as I said already now for the third time, needs for better guidance on how to manage the negative test results, both with some adaptation specific to the context of the private sector. Now, the last slide, if you turn to the next, There was also to review in the malaria context how to make the proper case management affordable to both patients, but also profitable for private sector providers. So find exactly the right balance, as a lot of the basic expenditure in private sector are out of pocket. The promotion of looking for innovation, especially on the reporting system, which is at the moment completely outside of the health management information system. And a request also to support the transfer of technologies, so to improve quality management system in the manufacturers in malaria endemic countries, so they can also access international funding and also increase the supply of quality medicines and diagnostics. And the last point was if the different elements will be good, probably looking at the example like the TB roadmap, to think about some generic and comprehensive guidance from WHO, which should not only be looking at medicines or diagnostics on their own, but as a whole package to how we can deliver proper diagnosis and treatment and contribute to surveillance and routine reporting of malaria in the private sector. So this is my last slide, and I thank you for your attention.
Okay. Thank you, Andrea. I think we're a little bit behind schedule, so I'm going to hand it over to Andre to talk about the SMC task force meeting. Andre, take it away.
Andre, you may need to unmute yourself. We don't have control over your phone. Andre? We seem to be having a problem with Andre. Larry, how do you want to proceed?
Well, I guess, Andre, if you, as soon as you can unmute yourself, please speak up. In the meantime, we've had a few questions from on the, so we might go through those. So let me see, there are 23 questions from Ibeth Gonzalez, so I'll read them here. I would like to...
Can just interrupt. Andre, if you can't join us by phone, please use the Skype login. That will allow us to see you and give you presenter rights. Sorry for interrupting, Larry.
Sure. So I would like to know what developing protocols for the new NMFI management in the private sector would mean. Should that be just to refer an RDT negative febrile patient to a healthcare facility, or would that be guiding use of antibiotics at the private sector? Keep going. And she says, talking about pharmacies and informal retailers. So Andrea, if you want to respond to that.
Yes, thank you, Larry. I think this has been identified as a gap in guidance, and referral, including also recognition of danger sign, has been repeatedly shown to be problematic even after training. So this is an area where, again, referral will not be the solution, and there should be some form of adapting the algorithm from IMCI on the let's say symptomatic definition of pneumonia, and including recognition of the most the chest ingrowing pneumonia, some of the form are more severe, and how to manage them. Clearly, referral will be part of the package, but then part of the treatment that accredited drug dispenser should give is probably also following the algorithm antibiotic. But as I said, this algorithm exists for the public health facilities. They are part of the IMCI training. And there has been very limited experience, mainly in pilot research only, to use the same algorithm and adapt it to the private sector. And that's where we need more work and more evidence based on how best to do that.
Okay. Thank you, Andrea. Andrea, are you able to speak? Okay, there's another question from Prudence. How to develop a robust malaria QA system in the private sector of proper use of quality assured RDTs and microscopy in the formal health sector, i.e. training a quality control of microscopists. Andrea, do you want to respond to that?
Yeah, this is a very difficult question, and we are struggling even with the public sector to have a quality management system which are effective, which can cover properly, and typically in the for microscopy, this is very, I would say, just skimming the surface of what needs to be done. So it's a very good question by Prue. Maybe I will put it again on systems available for public sector, including the recommendations on sourcing of which type of RDTs should be procured, what type of post-marketing control can be done before delivery or after delivery with the lot testing scheme. But it's a big area of work where, I don't know if Jane is with me here from the Unit project, if there are emerging lessons on this which can be provided.
Yeah, I guess I'll just say a couple of things. I mean, on the RDT side, and I think these will come out in the meeting report as well. So there were some sort of fairly basic interventions in terms of countries actually knowing what products are on the market or are available in the private sector, making sure that the technical specifications that the national program is using match those that are being used by the regulators. So there's a few fairly easy win steps that could get them on the right road. But then, of course, across all areas, enforcement is a big gap. So even if these things are in place, doing something about them when there are discrepancies is another huge piece. But clearly the public and private sector are going to need to work together. And I think we have some reasonable models for taking that forward, but knowing what the resources are, and having the resources, mobilizing the resources, and to get that done is another story. Anyway, I think I might have heard Andre come on there. No, okay.
Andre, can you speak now?
Hello, can you hear me? Hello?
Yes, we can.
Hello, can you hear me?
Yes,
Hello?
Andre.
Hello? Hello?
Andre, we can hear you.
Oh, okay. Okay. Good. I've been listening to you, but I don't know why you couldn't hear me. So just going quickly into this meeting that happened in February in Dakar of the SMC working group. Just as a bit of background, what happened is that coming out of the Access SMC project in 2017, we discussed within the Access SMC, let's say, group of organization, part of the project, on a way to have all SMC implementing countries to sit together to share experience with the objective of the most advanced country in SMC implementation to pull the country starting this intervention. So from there, we decided to have this meeting in between the previous and the upcoming campaign. So February has been the date where this meeting is happening, and this is falling into MMV because in 2013, when countries decided to start implementing SMC, the SMC working group was created, and MMV was given the seat of the secretariat, and all this was done under the umbrella of the WAN and the CAN regional network from RBM. So in 2016-17, you all know what happened with RBM. So we decided to take the lead while waiting for RBM to be revived, and this is how these meetings started 3 years ago. So for this meeting in Dakar, we had 90 delegates. So as we move on, we get more and more delegates coming to this meeting. We had this time 15 countries represented, one normative body, WHO, of course, 18 donors and implementing organizations from various origin, and 5 academic or research institutions were present in the meeting. So presenting the country achievement, this table on the third slide, this table is just to show that in 2018, Senegal did not implement SMC due to social health workers, social strikes, and so on in the country. So they didn't manage to implement SMC. And for Mali, when we compare the last 3 years, so 2016, 17, and 18, Mali is the only country where there was a degradation in the number of number of children receiving at least one dose of SMC. So this is mainly due to an overestimation at the beginning, but also some areas in Mali not reachable by the campaign due to security reasons. And coming back, next slide, on the specific case of Senegal, the preliminary analysis that the local NMCP did comparing the years 2016-17 and looking at the potential impact on 2018, obviously there was an increase in terms of the number of malaria cases in 2018 versus the previous year and versus the average of 2016-17. So these are very preliminary analysis, and they'll be doing a more rigorous analysis of their data, and this is supposed to be starting with the campaign this year, going back retrospectively into their data. Now, looking at the supply on the next slide, looking at the supply update, there've been yes, a growth in terms of update. We know all the supply issues that SPAQ got at the beginning of the campaign, mainly due to non-availability of quality assured sulfadoxine API, and this was solved in 2016. In 2017, there was some lack of funding that led to a slight decrease in terms of the supply. But in 2018, then about 81 million doses of SPAQ were supplied in the countries, all coming still from one supplier. But there is a second manufacturer that got EAP approved in February, and which is supposed to be starting delivering this year. So with that, we can aim to have about 250 million total capacity doses for the market. So this is something that is being solved. In 2018, the next slide, in terms of coverage, we reached the countries, they reached this year 19 million children, so a constant growth when we compare with the previous years. But still, there is a gap that is estimated to about 10 million children to be covered, and one country that is really carrying the biggest part of this gap is Nigeria. Nigeria carrying quite a big part of this gap for about 7 million children not covered yet. Of course, when we are talking of a target, we are talking of children below up to 5 years of age. In terms of funding landscape, on the next slide, in 2018, PMI is becoming the leading funding organization for SMC, closely followed up by the Global Fund. Then we have Malaria Consortium through GiveWell funds, the World Bank and WHO. MSF has pulled back on the SMC, though they'll be starting some pilot this year in Sudan. On the next slide, the prospective funding gaps for 2019 and 20. This is an estimation that was done by the Global Fund. It is estimated that in 2019 there will be about 9 million. I mentioned that 9 million children, 9.3 million children gap in terms of coverage, equivalent of about 37 million US dollars, and in 2020 this will go up to 9.5 million children, so 38 million US dollars. So basically a gap of about 40 million to be able to cover the whole target in most of those countries. So in terms of optimization, on the next slide, there were some discussions that countries are looking at now, following in Senegal implementing SMC up to 10 years. Several countries are considering this and questioning the reason or the opportunity to go up to 10 years in their own country. So thinking about this, in Mali, in 2 districts, there was a pilot conducted that was presented in the meeting. There is 5 years documented experience from Senegal. Several countries claiming an increased burden that is recognized as artificial in the 6 to 10 years old. WHO today not really wanting to have the discussion in the forum, but really appealing for evidence to be generated to lead to that discussion. Another question that several countries are considering is the timing and maybe the length of SMC. So Guinea showing some data of 5 months in intense transmission in SMC areas. Mali also showing the same kind of data, and wondering if there will be an opportunity to have 1 additional month on SMC to have a better impact. Once again, these were just presented, and WHO present in the room. Of course, that was not the forum to discuss eventual changes, but this was topics that were discussed. And Burkina Faso, for example, this year in 1 district will be implementing a pilot 5-year SMC campaign to see if there is any impact on additional impact on the transmission. In any case, there is a need to have good routine data to actually assess all those the potential of all those changes. So this meeting was organized under the framework of the SMC working group, pulling together several partners and MMB was central in terms of organizing all the logistic. But this is really the effort from several partners that are contributing to SMC on the field. We expect to have another meeting in February next year as well, and this will be kind of repetitive. About the SMC working group, I think I'll not go into details, but just to say that during this meeting it was discussed the hooking, I may say, of SMC working group, and as it was really recently created, the Sahel Malaria Elimination Initiative. The RBM advised that the SMC working group being attached to the Sahel Malaria Elimination Initiative, as it is one intervention that is really particular to the Sahel region and may constitute one key intervention specific to that region and contributing to that malaria elimination initiative. So we are working on that to make it effective. So I think I'll stop here, and sorry again for joining. I've been having issues connecting, so thank you.
Okay, thank you, Andre, and apologies from our side for the technical glitches. I think we're back on schedule, so we have a little some time for questions. So let me start off with a couple of questions for Andre. A question from Musa: the increase in cases in Senegal in 2018-2019 is that in children under 10 or the general population? And is this increase in Senegal seen in other non-SMC regions? Go ahead.
Yes, what they did in Senegal, the exercise was to take the target SMC population in regions where in 2016 and 17 they are actually implemented SMC, and compared to 2018 where SMC was not implemented. So these are in children below 10 years, because the policy in Senegal is 3 months to 10 years for SMC, and in regions where SMC is implemented normally.
So I think the question was, so was the increase in cases that you showed, was that in all ages, or in under 10s or in under 5s?
Under 10s.
Under 10s, okay. Another question for you: what is the global cost impact of including 6 to 10-year-old children? Is there funding? Can Guilin handle the production of SPAQ for other doses?
Okay, today the rough estimates that we have been doing with the London School, if we have to go in the entire region up to 10, we'll be doubling the number of children. So there'll be also some need to review the dosage of the tablets and so on. And the exercise they did in Mali, they did a cost analysis in the 2 pilot regions where they did this implementation up to 10 years. And in Mali, the additional cost was about the additional cost on the entire how will I say that? If you take the compared to applying SMC to 0 to 5 years, to 0 to 10 years, the additional cost was $1 per children. So per child, sorry. So the additional cost was calculated in Mali, and we can estimate that that will be the additional cost because we all know that the maximum of the cost for SMC is actually what is spent for supervision and so on, the additional cost, not the cost of the drug. And since this is the same population, there'll be limited additional costs in terms of supervision, in terms of the door-to-door distribution and so on, all the logistic around the campaign. So it will just mainly the cost of the drug. So no major. We are not thinking of doubling the cost of the intervention, but adding approximately 0.25% of the cost.
All right, thanks, Andre. Another question from Prudence, noting about the increase in cases in Senegal, and pointing out that it would seem to indicate that there is no effect on transmission, which I think we need to parenthetically say was never the contention. SMC
Yes.
had an effect on transmission, and potentially reducing immunity. Is SMC something that's going to have to be maintained indefinitely?
Oh, that's a good one. Definitely, the intent of SMC has never been to reduce, to have an impact on transmission, but rather to decrease the number of cases and to have an impact on death. Now, is SMC something to be used indefinitely? I don't think so. I think at some point, SMC needs to be coupled with something else that has an effect on transmission. At some point, there were some hypotheses. There is one study in Burkina Faso that will be associating SMC and ivermectin, targeting different populations. So the higher age group targeted by ivermectin, and then the eligible children for SMC receiving SMC. So expecting by doing this to have an impact on transmission. So I don't think SMC is something to be done indefinitely. And if we want to have an impact on transmission, definitely it has to be coupled with something, another intervention that has a real impact on transmission.
Yeah, and I mean, I would just highlight, no one asks whether ITNs need to be maintained indefinitely. So I guess I would bristle at the question about that. Okay. And another question for you, Andre. I think one slide mentioned increased burden in 6 to 10-year-olds. Is SMC just deferring cases to a different age bracket?
Increased burden?
I think the question is SMC shifting malaria burden to a higher age bracket, or is it just that what you're seeing is that, as we know and has been documented probably more extensively than any other fact in malaria, that the vast majority of burden of malaria is in the school age children, not in under 5s.
I think to respond to that, what triggered the decision from Senegal, for example, to go to implement SMC from the beginning up to 10 years was that they actually went into the hospital data and looked at the impact of malaria according to various age groups. And for them, the results they got was that there was no difference up to 10 years, and from 10 years and beyond, there was less cases. That what triggered the decision in 2014, 13 and 14, to start implementing SMC up to 10 years of age. So what other countries are seeing now is, for me, that's a personal opinion, there've been a lot of intervention targeting the under 5s. So this group of age is very well protected, and now most of the countries are now putting together a better health information system, and it's coming out into the data that the age group from 6 to 10 seems to have a high level of a high burden of malaria, which for me may be artificial. So just because the baseline initially was a bit biased. So for me, I think the highest burden of malaria should be up to 10 years old, and then beyond that, with a slow build of immunity, it may be less and less. But this is really a personal view.
Yeah, I'm going to take a little bit of chair's prerogative here, and just because a lot of the questions we're getting are about the 6 to 10 age group, and there are a number of groups looking at this age group for SMC for a number of reasons, including trying to answer the question of whether it would reduce transmission. I think the Senegal example is, I think, very specific to Senegal because it has never been a very high transmission area. So I think what they discovered was that, immunity in their population isn't like in intense areas of transmission where, after your 5th birthday, you're not at risk of severe illness or death to any large extent. They're seeing saw that age range pre-SMC to be higher. And so that was part of what drove their decision. But I think, there are a lot of questions about, the 6 to 10 age range, both whether we can afford it, whether it's the most effective approach, whether it impacts transmission. We don't necessarily have a lot of answers to those questions just yet. I think we will soon. So in the interest of time, I'm gonna actually ask Andre if there's anything else you want to comment on that, and then I think we'll ask Ricky and Mira to talk about the tools task force. Andre, any last thoughts on that?
Andrea or me?
Andre, you.
Oh, okay. So I heard Andrea. No, I think what's happening. I do agree that the transmission in Senegal has never been that high, but countries like Senegal, Mali, Niger are today, when they look at the data and they try to filter the 5 to 10 years old, it's clear that there is a serious concern for them there. So, as you said, something has to be done more on a more rigorous way to actually analyze those data and finally know what is the situation. But definitely, it's a source of concern for those countries. So yes, something needs to be done, and with the London School, we are in discussion to actually assess this in few countries to know exactly what is the situation, going back into their hospital data and then filter by age to see in terms of age what is the level of admission for malaria, and correlate that to the other data they may be available in those countries.
I think, the bottom line is it's an area of concern, but we need evidence to really make any kind of informed decision about whether it makes sense to expand the age group or not.
Absolutely.
So with that, I'll thank Andre and Andrea, and I will hand it over to Mira and Ricky to talk about the task force on case management best practices and tools.
Thanks, Larry, and hi, everybody. This won't take too long, and this is really just a report out for those of you that were in the meeting in Geneva earlier this year. You remember that we presented a table with 3 different sort of ways forward or next steps, and the center column has evolved into a task force for the management of best practices and tools, which Larry and Elizabeth have asked myself and Mira to lead on behalf of the working group. The purpose of this group is, as discussed back in Geneva, we really just want to collect all the best practices that everybody has been producing around malaria service delivery, so diagnosis and treatments, supply chain, and of course SMC. So Mira and I are going to be working with Konstantina, with Larry, and with Elizabeth to really just harness the inputs of the team and to try and to get everything together and uploaded onto the RBM website. So what we're going to do is, to begin with, we're going to send out an email, just collect these inputs, and then we're going to work with members, volunteers from the group to identify gaps and to try and rank things. I'm sort of waffling into what I said Mira would talk about, so I'm going to hand over to Mira, who's just going to walk through the next steps. But basically, this is a work stream that through the next 6 to 8 months will just try and harness the great work that everybody in the working group has done together to date and to see where we need to go.
Thanks, Ricky. And I think in both of the breakout groups during the last case management working group meeting, this desire, especially for NMCP folks, to really have a centralized location where they can find some of these tools and resources really came out. And so that was the springboard for making this a priority and turning it into a task force. So the next steps, as Ricky mentioned, are that first we wanted to sort of introduce this activity to the whole group today. And then our colleagues have set up an email inbox. And so our major focus is to have everybody share their resources and tools around case management. So, diagnostics, all the way to supply chain, quality improvement, quality assurance, to this email address that's listed here, cmwg@impactmalaria.org. Our focus is on the publicly available tools. So ideally, what we'd like to do is be able to just collect and share links to existing resources, such as the Severe Malaria Observatory or the CCM Central website that already exist, rather than to recreate another repository if one already exists. If your tool is not online already, but it is available for public use, you can share the actual document with us as well. But please just be sure that, within your organization that it's agreed upon that this can be added to the site. And then our next steps will be to collate these links and add them to a spot on the Case Management Working Group website. And then our hope is that at the upcoming ASTMH meeting, we'll have a small side meeting to report back to the group and share what we've done. At that point, we'd like to call for volunteers within the working group to help take us to the next step, which is to actually then review the tools and resources, vet them, and then also determine if there's any gaps that then the working group can figure out maybe next steps on in the future. So again, the first step is simply to collect all of the links and make them available. And then the second step will be with a small working group of anyone who's interested to carry that work forward to kind of maybe curate the list a bit better and consider how better to organize the tools in a more robust website moving forward.
I will add, for anybody who's sharing tools that have a national focus rather than a multi-country focus, if you can please ensure you have the NMCP's blessing to share them with the larger community first. I'm sure all of you would, but just to remind us, we don't want any surprises. So that's what we'll be doing together, and we look forward to working with all of you, and thank you in advance for sharing all your good work. Larry, back to you.
Thanks, Mira and Ricky. We have about 15 minutes left, so I'm going to ask Ricky to just open up the lines. I first want to, Elizabeth, are you now able to speak? Any comments you want to add, and then we'll open it up to the rest of the group.
Hi, everyone. I am able to speak, and I've been listening. I think it's been great presentations. I don't have any substantive comments to make. Thank you.
All right, and thanks, Elizabeth, for helping me to organize this. So I think we'll then open it up to anybody who wants to ask the question to any of our presenters. And just maybe one point, Ricky and Mira mentioned trying to have a meeting at ASTMH. I think we're going to try and have a case management working group meeting for those who are available at ASTMH. A major focus of that will obviously be the work on gathering and disseminating the tools. But there will likely be other things on the agenda. So with that, I will open it up to anybody who has a question. Don't all speak at once.
And Larry, this is Michael Eddy from CDC. Question
Sure.
for Mira and Rick, I think. So question is, how are they going to be comparing the tools to see which one represents the best practice? That's it.
Thanks, Michael. It's a good question. So I think together we had, the small task force along with Larry and Elizabeth had agreed that the first step is simply to gather the tools. And so over the next couple months, that's going to be the focus, to really, get everything that's out there, or not everything, but at least a good representation of useful tools that are out there and being used, and simply catalog them and make them available. Once that's done, hopefully by the end of the year, the next step will be to compile a small group of volunteers from this group to start sort of vetting and looking at the tools. And at that point, we may split off into, say, a diagnostics sub-team or a community case management sub-team or such, to kind of together vet the tools, reach out to some experts, and potentially whittle down the list or organize the list such that it can become more useful and reflect good quality practices. But I think together we agreed the first step is simply to gather. And then the second step will be to engage with the different groups to then start to call or vet or kind of, rank or however we decide the various tools to make sure that they're, conforming to best practices and global guidance.
Yeah, and this is Ricky. Just to add that I think once we get the tools uploaded on the website so we can see what everybody's got, I think the likelihood of what makes a document that we want to shortlist will become more apparent, and we'll be as transparent as possible in the reasons why, but it will come down to that small group again of volunteers, of experts really, to make that decision.
All right, thanks.
And I would just add, there are no perfect tools, and tools may work well in one setting and not in another. So I think we might even explore whether there's a way, once we have these tools on the website, and even after they've been curated and by expert groups, whether we also want to provide some method for countries or any participants to provide feedback on the tools and sort of how they can be improved, because I don't think anybody would argue that any tool is perfect and doesn't need to be improved anymore. But I think that's a very important point and something we have been thinking about. So any other questions? I see one question online. If there's been any other drugs other than SPAQ being looked at for SMC. Andre, would you have a response to that?
Yes. We know that DHA piperacin have been tested in the context of SMC in Burkina Faso in several studies with success. Internally at MMV, we are working on a combination of atovaquone progranil and amodiaquine eventually to replace the SP component, but this is really very very preliminary. At this point, we are testing it in healthy volunteers to look at the safety, the tolerability of the combination, and then we'll move forward if this first step is conclusive. So far we have those. I'll say those two. DHA piperacin definitely has shown to be effective, to be efficacious on the field, and the second combination being still at the stages of safety and tolerability studies.
Thank you. Then there's a question about dosing of 5 to 10-year-olds with SP8Q. Senegal already does that, so I'm not quite sure what the question is around that. We currently don't have the drugs aren't formulated, but excuse me. Any thoughts on that, Andre?
Hi, before Andre goes in, I think the question was with the current available preparations, which are targeting, the younger age group and weights that are on average for the under fives, is there adequate dosing of the 6 to 10 year olds? I think that was the question about assurance of sufficient dosing in that age group and how that was done given the current packaging that's available.
No, today the current packaging available through is for 3 months to 11 months, and then from 12 months to 59. What they are doing in Senegal, for example, they are mixing one high strength with one low strength to give to children 5 to 10 years old. There is we have not started yet, but it is in plan to have actually to study the appropriate dosage that will be needed. But the thing today is that the manufacturers don't want to go into that because it's not yet a recommendation by WHO, and they are not sure of the potential market that is out there for them. The study on the dosage, the exact dosage for that age group, this can be done theoretically. But now to produce that packaging, I don't think we are ready to have that done. So far in Senegal, on the PV side, they've not. Yes, they got 2 or 3 layer syndrome in that age group, 5 to 10 years old. But so far, that's what they managed to get on the field, and related to a higher dose or to the dosing. Not clearly established.
Okay, thank you, Andre. Any other questions from the phone? Okay. Another note, comment by Prudence. We did look into this, and though thought that we would need at least 2 age weight ranges to give sufficient doses to children to be effective. So I assume that means 2 additional weight bands beyond the current 2 weight bands. Prudence, is that correct? Am I? And then there is a question for Andrea, which is, beyond the report of the technical consultation, are there any more steps planned to move forward the private sector case management agenda?
Yeah, thank you. This is also a nice question from Ellen. We, as we do with all our, basically in consultations, we discuss a report back to the Malaria Policy Advisory Committee, which is going to review this and probably generate, endorse, refine the conclusions, recommendations. There is also, in addition to considering if we need a roadmap, because we can build on very good work by the Global Fund on a framework for engaging in private sector. There is also the PSI roadmap for introducing, promoting RDTs in the private sector, but we could have a more holistic guidance on private sector case management for malaria. Inside WHO, there is a cross-cutting working group of multiple initiatives, programs which have projects, activities, interest in engaging the private sector, and as part of universal health coverage. So we will also try to see how this interest can be mainstreamed in some global guidance, which is not specific and limited to maybe malaria only, but fits better into a more general health system strengthening initiative. So, but this is, let's say, all activities we are going to now put forward from now to September. Then there is a huge work which is normative, which is again on the guidance gaps that have been identified, the no malaria fever management, the diagnostics, how to promote in the private sector, how to have surveillance which works, how to ensure supportive supervision in the private sector. So there is plenty of activities that needs to be developed. I think for WHO, it's good to keep the focus on the policy and regulations and building on what has been shown to be inconsistent already now, on which countries can act probably more quickly, and on which WHO has probably influence among the various partners.
All right. Yeah, and Andrea, just on that last point, I think it is worth thinking about how the case management working group can work with you and WHO and perhaps even this cross-cutting group at WHO to move forward some of the agenda items from that private sector discussion. Obviously, some normative guidance would be welcome, but then thinking about how we translate that into programmatic action.
This is very good, Larry.
Yeah. Okay, we probably have time for one more question. If anybody on the phone wants to ask another question. I think if not, I think we'll close out this discussion. That first, thank Andre, Mira, and Ricky for their presentations, and thanks the others for joining. And we'd certainly, I think Elizabeth and I would certainly like to hear from you whether this was useful, whether we wanted to do these kind of calls and updates more frequently, or whenever. I know that we are thinking about another call once. Initially, this call was supposed to also include a presentation on an ICCM meeting that WHO was hosting. That meeting was delayed, so we're thinking maybe in the September timeframe we might also want to invite Salim to make a presentation, and if people are interested in that, or if there are other things people want to hear about, please let Elizabeth and I know. We want to make this working group a forum to share as much good information as we can. So, Elizabeth, do you want to officially close the call?
Sorry, just to thank everyone, and thank you for joining in and for the updates, and hopefully we can keep this going. I think it's a good thing to have these updates. Thank you.
Thank you all, and enjoy your evening, your day, or wherever your morning, wherever you are.
Okay, thank you all. Thank you very much.
And thanks also to PSI and Inform Malaria for hosting the webinar.
Okay.
Thank you.
Bye-bye then.
Bye.